Good afternoon, everyone. My name is Melanie Escher with the Arizona Telemedicine Program, and welcome to today's program. So today we've got some webinar tips and notes. So when you joined, your phone or your microphone were muted, but please use the Q&A for the chat function for any questions that you have. We have a post-webinar evaluation that will populate in a window behind your screen. Please go ahead and fill that out. There's also a space in there to let us know if there's other topics you would like to hear about. CME credit is only available during the live presentation, and in that evaluation, there is a code that you will be able to text. The number is in there. The University of Arizona utilizes a cloud CME platform. If you don't have an account, that's not a problem. We can get that set up for you. I will be sending out a thank you email to everybody when we are done to go over any of that information. You'll also have my direct email again, and you can ask me any questions. We are recording this and it will be available on our website after the fact. That information and URL will be in my thank you email to you as well. So as you registered, you also saw all of the outcome objectives, the accreditation statement, the relevant financial relationship statement. This is all for continuing medical education information. We have a standard disclaimer. I don't need to read it. You can take a look at that right there. And again, you can check out our website for upcoming webinars at the Arizona Telemedicine Program, the telemedicine.arizona.edu. Again, that information will be in my thank you email. And again, your opinion is valuable to us, so please go ahead and you'll find that code number and the instructions on how to log your attendance for the CME credit. And again, this webinar is made possible through funding provided by the Health Resources and Services Administration, Office for the Advancement of Telehealth. So I'm going to go ahead and introduce Ernestine Nasiatua, and she is my partner and collaborator with the American Indian AIH AHEC. Whatever. So I'm going to go ahead and pass this over to Ernestine. She's going to talk a little bit about that, and she will introduce our speaker for today. Ernestine.
Great. Thank you, Melanie. Hi, everyone. My name is Ernestine Nasiatua. I am the Grants Program Coordinator with the American Indian Health Area Health Education Center. We are always grateful to the Arizona Telemedicine Program and Southwest Telehealth Resource Center to collaborate on events like today. So just a short abbreviated summary about the American Indian Health AHEC. The American Indian Health AHEC is one of 6 area health education centers in Arizona. The American Indian Health AHEC works towards enhancing tribal healthcare systems and strengthening current workforce strategies and solutions. So we partner with a lot of organizations for various activities, including youth healthcare career exploration programs, community-based experiential training, AHEC scholars, community immersions, and also events like today, continuing education for healthcare professionals. We are honored to welcome Dr. Yvette Brown-Shirley, a clinical assistant professor of neurology at the Barrow Neurological Institute in Phoenix, Arizona. Dr. Brown-Shirley is an enrolled member of the Navajo Nation and was born and raised in Flagstaff, Arizona. In addition to her clinical and academic roles, Dr. Brown-Shirley serves as the director of Barrow's Native American Health Equity Initiative, where she works to provide culturally sensitive neurological care to tribal communities across Arizona. She is also the medical director for NABI, one of the largest Native American high school basketball tournaments in the country, and continues to support athletes as an unaffiliated sideline neurotrauma consultant for Arizona State University and the National Football League. With that, I'll turn it over to Dr. Brown-Shirley to begin today's presentation.
All right, thank you, Ernestine. Let me share slides here. Okay, are we good to go?
We're good to go.
Thumbs up. Perfect. Thank you, Melanie. All right, yeah, Yvette Brown-Shirley Yinisha. 22 Inashla. Might excuse me, Bush's Chin, Touch Me, As Ernestine had mentioned, I am a proud enrolled member of the Navajo Nation. So I just wanted to introduce myself in my native language in case I have some relatives up there today. So let me just begin. So we're just going to talk about recognizing and managing concussion in youth and adolescent athletes. So please, if you have any questions, shoot them into the chat. I would love to answer them as I'm getting going through the presentation so we can answer it as you have the questions. So please do interrupt me. So just some objectives. We're just going to go over what is a concussion, really talk about the pathophysiology. We'll talk about the signs and symptoms of a concussion, the recommendations, and the guidelines for how to get our student athletes back to school, back to playing, and then also when should you be thinking about referring an athlete to a specialist such as myself. So these are just recommendations that I just wanted to put out there. These are predominantly used in the outpatient clinic setting and will be used predominantly in the concussion setting. So we'll go over the definition of concussion, but it's going to be the definition is mild traumatic brain injury without any intracranial abnormality. So that's concussion. It shouldn't be used for sideline, for use in the ED or inpatient settings. So let's just start at the basic level. So let's just start with the conceptual definition. Because concussion is actually involved in many specialties, we don't have like one unified concussion definition, but in the concussion and sport group, who meets every couple of years, we do have a sports related concussion definition, but as you'll see here that it does not lay out diagnostic criteria. So let's just go over this. It's going to be a little bit of a busy slide, but I just wanted to go over here so we're all on the same page. So traumatic brain injury is caused by a direct blow to the head, to the neck, to the body, resulting in an impulsive force being transmitted to the brain that occurs in sports and exercise-related activities. This initiates a neurotransmitter and metabolic cascade that I'll briefly talk about the pathophysiology, which can include axonal injury, blood flow changes, and inflammation affecting the brain. The symptoms and signs may present immediately or evolve over minutes or hours and commonly within days and can be prolonged. So there is no abnormality seen on standard neuroimaging studies, but in the research setting, abnormalities can be present on functional blood flow or metabolic imaging studies. Sports-related concussion results in a wide range of clinical symptoms and signs that may or may not involve loss of consciousness. The clinical signs and symptoms of concussion cannot be explained by another reason, so drug, alcohol, medication use, or other injuries or other comorbidities. So that's the conceptual definition of sports-related concussion. If you're really interested in concussion, especially sports-related, this one is a great consensus statement that was just published. This is the last meeting that they had was in 2022, and so this is a great statement just to review of interest to you. So like I had mentioned, there is no diagnostic criteria laid out in that definition. And so we had a classification system that had been in place since 1993. And so this was really all we had in terms of working on the TBI classification. This is just traumatic brain injury in general. So I wanted to briefly touch on this. So we have mild, moderate, and severe on the spectrum of traumatic brain injury. For a mild traumatic brain injury, you have certain criteria. So based on the Glasgow Coma Scale, on scene or like on the field or in the ED, this is where you can usually find that documentation. So it'll be a GCS of 13 to 15. PTA means post-traumatic amnesia. So you can either have anterograde or retrograde amnesia around the time of the head injury. So you will ask your patients if they had any loss of memory around the time of the head injury, and then you'll try to figure out how much time was lost there. And then for moderate and severe, the GCS scores are going to affect where you would classify a patient. So even though this is concussion based, I just wanted to touch over moderate and severe. And as you can see, moderate is like right in the middle. So GCS of 9 to 12, post-traumatic amnesia, 30 minutes to 24 hours. And then severe is going to be GCS 8 or less, and a post-traumatic amnesia greater than 24 hours. And so when we go back to the mild category here, this is the only category that you're going to look to see if there's any abnormality under our imaging, because it's going to dictate which column of mild traumatic brain injury we are looking at here. So if they have imaging, this is where you're going to. Not all concussions or head injuries need head imaging, but if they do, this is where it'll help you decide. So if they have a normal MRI or a CT of the head, then that's what we're talking about with concussion, or it's called an uncomplicated mild traumatic brain injury. If there is skull fracture, if there is brain bleed, that puts us in the category of a complicated mild traumatic brain injury, or more recently, it's mild traumatic brain injury with neuroimaging evidence of structural intracranial injury. So that's a different category. So that is not concussion. that's one step up from concussion in terms of severity. So I just wanted to lay that out for you guys. And now there is more of a working diagnostic criteria placed forth by the rehab, so the PMNR group and physical medicine rehabilitation group, and they put forth some diagnostic criteria from 2023. So just recently they had put this together, and this is just something to look at. It's in this this article here, which is a good review. Again, if this is something that interests you, we can look at the diagnostic criteria. So the first one has to be a mechanism of injury that is plausible. So this is, there has, again, it's hard to quantify forces, and it's hard to quantify every one specific concussion threshold, but I have had a referral for someone being hit in the head by a granola bar. Like, is that plausible? Is that enough force that could transmit that force to the brain to cause that metabolic cascade? Questionable, right? As opposed to a 300-pound, lineman tackling you, or being in like a motor vehicle accident and you're traveling at highway speeds and then you get into a car accident. So different, again, you're going to be looking at the mechanism of injury there. And then you're going to look at the clinical signs. You want to have one or more of clinical signs. The symptoms, you would want two or more symptoms, and we'll go over the symptoms, the signs and symptoms on the next slide. The clinical examination and laboratory findings. So that is looking at cognitive impairment on clinical examination, or balance impairment on your examination, or ocular motor or symptom provocation in response to exam maneuvers that you can do as part of your concussion evaluation. And then laboratory findings. So there are some settings, there are some hospitals that are using biomarkers as a way to test for traumatic brain injury, not necessarily concussion, but these are more higher grades of traumatic brain injury. And so that one is a little, there should be an asterisk around there, because not all facilities are using biomarkers at this time. And then the criterion for the neuroimaging abnormality there. So that is going to determine if you're going to be in that category of, skull fracture and brain bleed. So in that separate category, just a notch up in severity of concussion severity. So if you put all those together, then you're going to be left with a diagnosis of mild traumatic brain injury. And again, at the bottom of the screen there, you're going to see that there's a little bit of the old definition of what a mild traumatic brain injury is not. So it is not, does not have a loss of consciousness greater than 30 minutes. And then the Glasgow Coma Scale cannot be less than 13. And then the post-traumatic amnesia cannot be greater than 24 hours. So those are all going to be categories that that would shift you out of that mild traumatic brain injury category there. So the pathophysiology here. So I didn't want to go deep into the pathophysiology, but I just wanted to illustrate that this is all at the cellular level. So this is why we can't see concussion on imaging, is because this is all cellular level. So we have this neurometabolic cascade that's taken place, where the impact forces cause neuronal stretching, and that leads to an ion influx and efflux of potassium and calcium. And so the pumps so there's a massive potassium efflux and a calcium influx. And so there's an energy crisis that is happening here to increase glucose metabolism. There you go. And there's also at the same time reduced cerebral blood flow there, despite an increased demand and trying to increase glucose metabolism. So that leads to an energy crisis there. And so that's really what's going on at the cellular level, to try to illustrate that this is why we cannot see concussion on your typical MRI or CT. So let's go over the signs and symptoms here. So the signs of a concussion and what someone is going to observe is going to be, and this is who I'm usually asking, like the parents, or I'm asking, the parents, if anyone on the sideline, athletic trainers or coaches had noted this in their child when they had a concussion. So physical, they could be slow to rise, clutching their heads, trying to shake it off. They might have some difficulties with like walking, balance, and then worst case scenario, you're having fencing posture, which is concerning for an impact seizure, and then loss of consciousness where it was witnessed by someone where they were completely out. And then the cognitive category, they can appear dazed and stunned, a blank look in their face. They might be answering questions slowly or inappropriately. They might be repeating their questions, and they might not be able to tell you what happened about that injury or about that event. And then emotionally, they can get aggressive, agitated, more emotional, and just irritated at that time. So symptoms is what I'm going to be asking the patient at the time that I'm seeing them. So physical symptoms, cognitive symptoms, emotional, and sleep are the bigger categories that I'm screening for. Physical, so post-traumatic headache is the number one most common symptom, and that's very common to see, especially in our neurology clinics. You can have dizziness, balance issues, vision changes, light and sound sensitivity. Cognitively, the most common symptom I see is difficulty concentrating, and then behind that's going to be brain fog, decreased processing speed, difficulties multitasking, memory issues. Emotionally, they might be, again, they might seem more aggressive, they might be more quick-tempered, they might feel more emotional, and they just might feel more irritated. Sleep can be a pendulum. They could be more drowsy, they could be sleeping a little bit too much, or they might be sleeping too little, and then overall some fatigue that might be also demonstrated as a cognitive endurance. They might just be more tired after longer days, more cognitive heavy tasks might make them feel more tired. In our concussion clinic, we do have symptom scales that we follow at every single point that we see our patients. They are filling out a symptom scale, and I just wanted to list the various symptom scales that are used for concussion specifically on the side here. So in my notes, if you were to read some of my notes, I at the end of all of that, when I hear about all of the symptoms, I'm putting their symptoms into these clusters of subtypes of concussion symptoms. And so the bigger subtypes that I'm putting them into are either post-traumatic headache, vestibular, ocular, motor, cognitive, and mood. Those are the bigger symptoms. And then we'll have sleep and cervical strain as associated conditions that can affect someone's recovery period. So this is what you're looking for in terms of, so you're talking to the patient, and this is something, these are the red flag signs and symptoms that you're looking out for and you're listening for to look for something worse than a concussion that might be occurring, that might prompt, if they haven't seen an urgent care ER, like getting neuroimaging. This is really what you're looking for here. Is going to be worsening headache, repeated vomiting, seizures, inability to wake up, slurred speech, weakness or numbness in your extremities, decreased coordination, unusual behavior, if they're increasing confusion and combative. So this is where, we're looking for a brain bleed, we're looking for strokes, we're looking for cervical injuries. Those are all going to be on the top of our heads when we're evaluating these patients pretty acutely after their head injury. So, after talking with the patients, kind of getting the injury characteristics and asking about their signs and symptoms, we're trying to figure out at this point, are there symptoms in the history consistent with a likely concussion? What are the patient's risk factors for a prolonged recovery? And a typical recovery is 2 to 4 weeks. I tell my patients 2 to 4 weeks is going to be our typical timeline of recovery, but a larger patients, like 75 to 95%, depending on the research that you're reading, is recovering within 3 months. And so for our kids though, because they're very healthy, 2 to 4 weeks is going to be that window that you're looking to expect recovery. And then is the patient at risk of having problems with academics or return to work if they have work? Your biggest concern is, can they get back to school in an appropriate setting? And do we need to implement any accommodations or give them the formal return to school guidelines? So looking into the risk factors for prolonged recovery, the ones I'm looking for is going to be, because they're filling out the symptom severity score, I'm looking at how high their subjective symptom burden is. And we're looking at, do they feel like they're more on the mild to severe end of symptom burdens? And then I'm tallying it up every single time. And basically the higher their subjective symptom burden is at initial consultation, the longer the recovery might be if they have a higher symptom burden, as opposed to someone who has a lower symptom burden and is doing quite well a few days out. So that's something that we will track and record every single time they come to our office. So I'm looking at history of concussion or intracranial injury. So I'm asking them every single time I see them for initial consultation, what is your, let me see here, what is your concussion history? How many concussions have you had? And what was the mechanism? So if it was sports related, if it's all been in the same sport, and time to recovery, and what specific measures helped them to recover? Did they need physical therapy, occupational therapy, speech therapy? Did they need medications for headaches? So how intensive was their recovery process? Oh, let me see. I see some questions here. Let me see. I just want to answer them real quick. So Jose says, can diving into water cause a concussion? Well, it depends, right? Like if they're on like a diving board, and it's very high, right? Sometimes it's like diving into cement. So possibly, yes, there is a possibility that diving into water can cause a concussion. And I will, Jose, I will not be talking about shaken baby syndrome during this presentation. Okay, so back to the risk factors for a prolonged recovery. I'm also asking them their personal history and their family history. So I'm asking if they've, there's a difference if they have a history of migraines, if they have a history of ADHD, if they have a history of anxiety, depression, PTSD. Those are all going to be very important to their recovery, because those are all chronic processes that are happening with the brain already, and then we sustain a head injury, and so those can dictate and drive your recovery depending on how well controlled or uncontrolled they are at the time of concussion and during their concussion recovery. And so I'm also assessing how supportive they are in terms of social support, in terms of parent involvement, in terms of like school, friends, to see if they feel supported at the time of, during their concussion recovery. And then I'm also looking for, because we know prolonged recovery can be associated with adolescents, like the older adolescents, like the higher teens, female sex, lower cognitive abilities or learning difficulties, if they have a neurological psychiatric disorder, and if they already have existing pre-injury symptoms that are significant, and then family and social stressors at that time. So that's all just talking with them, kind of getting the history, and then we move to the physical examination here. You're going to be doing your typical neural examination. You're going to be looking for focal abnormalities, because your examination for the most part should be non-focal for concussion. I tell my patients that is a diffuse brain injury. It's not like a stroke where it's affecting one part of the brain. So I should not see any, right arm weakness, any leg weakness, anything that's very focal on my examination. So, we're doing mental status, balance, strength. We're looking for any scalp or skull abnormalities, especially around the area of the impact. And if there was any signs of cervical spine injury, deteriorating neurological function. So what is that, Dr. Brown? And so the indications for cervical spine injury, you're going to be asking and looking for weakness or numbness in the upper and lower extremities. We can, our athletes can experience stingers. So that would be, I think, a temporary change in neurological function of their arm. Usually it's going to be like a stinging sensation, a sensory change, and then that should go away pretty quickly though. But if these continue on, that's what we're going to be looking for in terms of a cervical spine injury needing further evaluation. Signs of a neurological deterioration. Again, this is not concussion. This is because they maybe have an epidural, a subdural hematoma that is increasing in size. And again, that's not concussion. That's something worse than concussion that we need to be evaluated for. So decreasing levels of consciousness, focal neurological deficit, again, not to be expected with concussion, increasing confusion, severe worsening symptoms, increasing headaches, repeated vomiting, unusual behaviors, seizures, and slurred speech. Let's see here. And the question is with kids is going to be to radiate or not. And so this is going to be this is going to be again ER. This is how they are facilitating. And I will use this guideline if I'm seeing patients like couple of days out from a head injury. I'm going to be using these guidelines to help guide my radiation. Do I get a CT or not? Question about my pediatric patients. And so again, you're looking for the GCS, you're looking for signs of basilar skull fracture, altered mental status. So you're looking for those signs that I had mentioned: vomiting, loss of consciousness, severe headache, and severe mechanism of injury. So this one's going to be if you had a fall greater than 5 feet, MVA with ejection rollover or fatality, a bike versus peds or vehicle without helmet specifically is struck by a high impact object. And then, the PCARN is what I usually use to help answer that question for me. So after you've talked to them, you've talked to parents, and you've done your physical examination, you're trying to decide your likelihood of diagnosis. Is it suspected? Is it a definite? Is it probable? How likely is this that we're dealing with concussion and nothing worse? And this is where you get to talk about time to recovery. For kids, it's going to be 2 to 4 weeks, like I had mentioned. The likelihood for a complicated or a prolonged recovery. Do we need to start any medications? For most of my patients, my approach is trying to get them with as little medication as possible, a lot of education and anticipatory guidance, and just close follow-up for my concussion patients. And then over time, they will start you will get an idea of if they're going to be a typical recovery or atypical and a little bit more complex. You're going to be, trying to facilitate the return to school guidance. You can go over the protocols, and definitely if they need accommodations, please do give it to them. That's only going to help them. And we'll go over what that looks like, and then return to physical activity, sports and recreation guidance. That's where we'll also go over here in the next few slides. So putting it all together, this is actually a nice handout that I've seen used by primary cares. And if I see this in the referral documents, it's gold, because it's going over everything that I need as a specialist, but also, you as a primary care or the first line treating physician or medical team that's going to be seeing the student athletes. So let's just zoom that in a little bit more. So it's going into great detail about the injury characteristics, which are always helpful. It's going over the early signs. It's going over seizures. It's going over amnesia. This is all information that we should be gathering for our patients. It even includes their own symptom checklist. This is a lot more truncated than the one I use in my clinic, but it's still a symptom checklist and something to watch over time with your kids. It's going over the red flags, which is very nice and laid out in there. And it says refer to the ER if you have any of these symptoms or signs. And then at the end, you choose your diagnosis and follow up. So you can see there that there are specialists at the bottom. So concussion, like I had mentioned, can be seen by, or traumatic brain injury can be seen by several specialties. So neurosurgery, neurology, sports medicine, physiatrist, so physical medicine, rehabilitation, and if they need psychiatry involved there. So those are all, and neuropsychology up on the top there, are all specialists that cater to the concussion patient population. Okay, so just to go over the recovery plan, there used to be a mantra of like cocooning. So you don't do anything, you stay in a dark room, no screens, you wait until symptoms get better, and then you get back to your life. Now we're more aggressive with returning our patients back and our student athletes back into school, back into life. It is like 24 to 72 hours of relative rest. It's not even absolute rest anymore. It is relative. So you are allowing them to do what they want to do on a day-to-day activity, and just keeping their symptoms sub-threshold. And if they experience mild symptoms, that's okay. You can continue on. A lot of the most common questions I hear is, can my daughter or son get on their phone? And I tell them, yes, if it's not causing symptoms, then fantastic, let them. If it's causing symptoms, then just see at what point they start feeling symptoms, and can they determine when it's only mild versus when it starts to get more severe. And that'll give us some insight into how to prescribe more. You know, it's more of a gradual return to screen time if it becomes an issue and it's starting to cause more severe symptoms at that time. And so number one rule is removing them from that situation. You do not want them to hit their head again. I tell my patients, number one rule of concussion is don't hit your head. That rule gets broken all the time, usually by my teenage boys. So we number one rule, don't hit your head again, remove them from play. And then educate. So this is all anticipatory guidance and telling them what to expect in the typical recovery pattern that they should be experiencing. You want to adjust and accommodate. So again, you want them to rest, but not for too long. So that 24 to 72 hours of relative rest, and then you're getting back into your gradual life and what you want to do. And then academic accommodations. So please do write those academic accommodations for your student athletes. After an initial consultation with my patients, especially sports related, I will usually see them 1 to 2 weeks later, depending on how aggressive we're trying to be to get them back into sport. Our kids can turn around really quickly, so it might be the next week where they feel completely fine. So I just write academic accommodations for a week or two until they feel they should, and the academic accommodation should be a dynamic document that's going to be changing every single time they see you. And then you also want to just relay a pacing strategy. Because I alluded to there's an energy crisis with the pathophysiology of the brain. I transfer that to as an analogy for my patients that the brain is a battery that usually, you know, day-to-day non-concussed, we usually drain the battery at the end of the day and then we have to go to sleep and then it's full again, okay? With concussion, our brain battery is just more inefficient and it just drains a lot quicker, okay? But once people start to experience more symptoms, it's gonna be more when their battery is more drained. So usually towards the end of the day, towards the end of a hard class like math or science, they're notorious for causing symptoms towards the end of the day, especially. So we're going to be implementing a pacing strategy where once they start feeling a little bit lower on that battery level, then they're going to take a break, 5-10 minutes. You know, if they're in school, then it's going to be just kind of getting them out of that classroom, just in the hallway, and just kind of taking a break. Sometimes the classrooms can be very loud and very bright, and that can be also symptom provoking at the same time. So we want to reduce the demands, rest and refuel very frequently. The goal is that they will gradually return back to life with the expectation that they're going to experience some mild exacerbation of symptoms, and that's okay. So I really emphasize with my patients that if they feel any symptoms, they're not hurting the brain at all. They're not causing any brain damage. It just means if they experience moderate to severe symptoms, they're just going to drain their battery a lot quicker. They're going to go past empty, and it's going to take a lot more time to get full again. So, and the goal is that they are returning to their activity within an hour. So if they are pushing it way too much and they are drained, they're taken out for several hours. I hear from some of my patients, they're out for like a day or two after a certain activity. Then I say, then you pushed it too much and we need to come back and see where we can go, how we can baby step that progression a little bit further. So this is this is such a beautiful example of concussion management. It just shows the overlap in clinical profiles. This is from 2019. I wish patients, were this clear cut. It's never this clear cut. Usually my patients that I see in our concussion clinic these are all happening at the same time. So it's kind of a dance to figure out, how to navigate this and how to get them through this. But it really is just a beautiful outline of how the clinical profiles that I had laid out in the previous slides, how there can be seen on physical examination and then targeted treatment that you can that you can recommend for that patient depending on the clinical profile. So the timeline and what we're looking for our patients here. Ideally, if we can, we are looking for baseline testing and education. That is not done in some patients, and that's okay. But the gold standard is that we have baseline testing, because then we're comparing, we're doing post-injury testing, comparing them to themselves instead of normative values. So sometimes we do not have that, but if we do, it's fantastic. We have concussion point of injury. We're trying to get them back into the classroom first, but also very shortly thereafter, we're trying to get them back into physical activity and to their sport. And then we'll watch them through the full recovery to see how they do. And then hopefully do very well after that. I have to emphasize the multidisciplinary. So a lot of people are involved with someone who has a concussion. So it could range from your medical team to everyone at the school, and then everyone at home, and if they work, and their social support. So this takes a lot of people. It takes a village to get someone through with a concussion very successfully. And I just wanted to just put in some pointers for referrals to a specialist. And their specialist can be not just me. So I'm a sports neurologist, but it could be a sports medicine doctor. It could be physical medicine rehabilitation. Those are the bigger, and neurosurgery sometimes can be your referrals to your specialist. So these are some pointers. So persisting symptoms. So definitely, right, we're getting close to that 2 to 4 week mark. And perhaps we're not even close to getting recovered. We're not on that path of better recovered, which is what I expect from my patients. Or they start to get better and then we plateau, and we're plateauing for, you need some help to figure that out. And then worsening symptoms, which is what we don't expect for concussion. So why are we going in the opposite direction of better recovered? If there's atypical symptoms, if they have any concerning exam findings, they have a complicated history. Maybe they've already had 5 concussions, and they have, a couple of prolonged recoveries. Maybe they need specialized treatment, like PT, OT, speech. They need a rehab team to help them through this. Maybe they need psychiatry, neuropsychology. Maybe they need a big team to get them through. Or they have neurological disorders. So maybe they have migraines, or maybe they have epilepsy. And it's a little bit more complex than your typical healthy, teenager who's going through their first concussion. So those are all reasons why we would refer to a specialist, that I would recommend referring to a specialist. We have a scheduling coordinator with our clinic just in case, to give you someone to refer to. So Christine is one of my office staff, and so she's wonderful. So she's more than happy to answer questions about the patient population that we accept in our clinic. So I just wanted to introduce our team at Barrow. We have the Barrow Brain Injuries Sports Neurology Center. We have the Barrow Concussion Network, which I will just briefly talk over, which is our second opinion portal, which offers a second opinion portal for our athletic trainers here in Arizona to submit cases to our concussion specialists, so me. And then up here, I don't know if you can see my pointers, but we have Dr. Zeman, we have myself, we have Dr. Bullum up on top, who is our neuropsychiatrist. Unfortunately, she does not see under 18, but she's still a great resource for our team. We have 2 sports neuropsychologists, and we have a program manager who her background is athletic training, and then we have a social worker in our clinic. We also have a domestic violence clinic program that we offer to the community. And then I run the Native American Health Equity Outreach Program. And so this is one of our initiatives. So NABI is happening next week. I will be there providing the sports neurology coverage. I'm very excited to work with our Native American athletic trainers, so our student athletes are taken care of. So this is the Barrow Concussion Network. I just wanted to put a shameless plug in for. So we operate for the entire state of Arizona. We provide prevention and education. So if you ever feel like your facility needs some more concussion education, more than happy to provide a similar type of presentation to your facility. We have concussion research that we are doing as well. We have baseline testing that we provide for the whole state of Arizona. The athletic trainer at the schools have to be registered with the Barrow Concussion Network to offer this. And then we have post-injury care. So this is where our athletic trainers can log into our second opinion portal and can submit a case. So if they have any questions or concerns about a specific student athlete that they want to talk to a sports neurologist about, they can submit a case, and we will go over that case and submit our opinion to that athletic trainer. We do post-injury impact testing in our facility, and then we have the neuro consultation available for our student athletes. So here we do, and I'll go over the requirements for the state of Arizona just so we are all on the same page, but our student athletes have to undergo concussion education at least once in their academic careers. And so the state of Arizona uses the Barrow Brain Book. And so that's another way that we are providing the concussion education and meeting that state requirement, that state law requirement. And then if we have baseline impact testing for our student athletes, this is when it's usually done before they start participating in the sports. If we have a head injury, then we have the post-injury impact that we can utilize to compare to the baseline. And then if the athletic trainer would like to discuss the case, then they log into our second opinion portal and submit a case for us. So this is, we have had concussion laws in place in Arizona since 2011. We were a 15th state to pass concussion laws here. So you'll see here that we legally, the athletes need to be cleared by a healthcare provider with specific training, the evaluation and the management of concussion and head injuries. And so in the state of Arizona, that can be a licensed athletic trainer, an MD, a DO, a nurse practitioner, and a physician assistant. But it says with specific training in the evaluation and the management of concussion, but I'll go over the AIA constitution and bylaws. So just so we are all on the same page here. So concussion education, our student athletes have to complete this online concussion education course, which is that Barrow Brain Book that I had mentioned there. And they only have to complete it once. And so the education component is that all AIA participating schools have to have a concussion policy on file that discusses education, removal from play, return to play, and return to academics. All parents and athletes have to sign a form acknowledging education about concussion. And then the removal from play can be initiated by an athlete, by a coach, a licensed athletic trainer, the team physician, official, or parent. And then only an appropriate healthcare professional can refute the diagnosis of a concussion. And then return to play. So an athlete is not allowed to return to play on the same day that they sustain a concussion. It says they should be evaluated by an appropriate healthcare professional that day. And then they should be medically cleared by an appropriate healthcare professional to resume participation and practice in competition. And then they will follow a return to play protocol that I'll go over. And then a return to play should only occur after an athlete has returned to school with full attendance without any academic accommodations. And then it also outlines here that only the professionals here, so the athletic trainer, the MD, the DO, the nurse practitioner, and the physician assistant in the state of Arizona is allowed to return an athlete to play. And then there are, so this was just, I feel like just revamped this year, where it actually outlines here that cognitive rest, including reduced screen time, may be recommended for the first 24 to 48 hours, like we had mentioned. Student athletes can engage in subsymptom cognitive activities as tolerated. So that's that relative rest period there. And then cognitive exertion should be stopped if concussion symptoms exacerbate, is more than mild and brief. And so then again, that's where we're just going to have them stop and rest for a little bit. And then maybe resumed once symptoms have returned back to their prior level. Schools should have policies to facilitate academic support. Not all student athletes will need academic support or return to learn strategy. And while return to learn and return to sport can occur in parallel, students should be should be in school without any accommodations before they return to the unrestricted full contact practice and gameplay. And then returning an athlete to the classroom following a concussion should follow a return to learn progression. And then at the end or the beginning of the game, the coach must certify that the official that the equipment is in compliance with safety regulations and properly fitted. If a helmet comes off during gameplay, they have to come out for one play or have a timeout called to have the equipment reassessed so that it is fitting well. And these are just some resources for some professionals. If this is something that you enjoy and just want to learn more about, the Heads Up for Healthcare Providers is a pretty good resource to get you some more information there. And there are some tools, so some guidelines. They have that ACE form that I had just gone over. It's a great one pager. And then they have some standardized letters for school accommodations, just for some examples and references. So it's a great time to be in sports neurology and concussion right now, because we are trying to further the field. So we are trying to find objective diagnostic biomarkers and tools. I still don't have a tool yet to tell me if someone has had a concussion. It's all based on clinical. It's all clinical judgment at this time. We're looking for age-specific management protocols. We're trying to predict recovery trajectories based on someone's, like, if they have a complex history. Those are more helpful. We're trying to, again, look more at sex-based differences in injury or recovery, which is at all levels, and not just like at college levels or professional levels. We're trying to figure out the cumulative effects of subconcussive impacts, trying to figure out the rehab strategies, prevention strategy, effectiveness. And then we have the blood biomarkers, which are in research right now. And so I'm hoping in the next like 10 years or so, we're going to have something that we can use in clinic or on the sideline to help us try to predict who's going to have a positive CT, who's at risk of, needing a ride to the emergency department right then and there. We're going to try to, figure out advanced neuroimaging. So like I mentioned, we're only using MRI and CT. We're not using DTI or functional MRIs at this time. Those are still in research stages. So now that's going to be the next stage of how can we use advanced neuroimaging to help us determine diagnosis, prognosis, and recovery. We're trying to look for vestibular ocular motor biomarkers. So that's if you've heard of more of those eye tracking devices, how can we use those more as part of our, again, to help diagnose, prognose and help determine recovery. Looking at genetic factors, trying to figure out new and novel ways to approach concussion from a rehab standpoint, and then wearable impact sensors, so like mouth guards. The NFL already puts a lot of technology into helmets. So how can we start implementing that and using that information? So just some key takeaways here is recognition. So as soon as someone is recognized to have a suspected head injury / concussion, it's just removing them from play is very critical, and getting to an individual who knows how to manage concussion. And then once that individual is in that care, trying to individualize management at that time based on symptoms, based on risk factors and personal history. The multidisciplinary care. So just kind of getting the team involved to make sure everyone is on the same page, even if that's using papers like, our return to play protocols, our return to learn protocols, and just kind of keeping that line of communication open. I frequently call my school athletic trainers once I've seen one of their athletes, and they all will have my cell phone or my email so that we can communicate during that time. And then, when to refer to a specialist if needed. There we go. Okay, just about a couple minutes, so 10 minutes left. Any questions or concerns or any questions?
Doesn't look like we have any questions in the chat, but as a parent of a student athlete when she was in high school, yeah, it was interesting to watch as the development of different protocols over the years, and they're much more immediate, and not waiting and going ahead and getting those kids the help that they need right away, which was nice to see that development. Looks like we got something that went in here. If you look in the chat, we got a long question here.
Let's see, today, Dr. Brown Shirley, my name is Caitlin. She's from Mukochikai. She's raising a 4th-year PhD student in the medical pharmacology program. Hey, congratulations. In Tucson. Let's see here. Oh, she's a rising. That's what she's a rising. Okay, my research focuses on neurocircuitry underlying post-traumatic headache, a common consequence of mild traumatic brain injury. While we currently work with preclinical models, we're very interested in expanding into clinically translated research. Yep, I would agree. I really appreciate your insights during the webinar. I was curious whether you or your colleagues at the Barrow might be open to potential collaborations in this area. Yes, please do email me. Let me see here. She says, I'm exploring resources related to TBI in American Indian communities. So am I. If you know of any ongoing efforts, programs, or key contacts in that space, I'd be super grateful. Yep. yeah, more than happy. It sounds like we need to connect
Great.
because
I can help make that connection, Dr. Brown Shirley.
yeah,
Absolutely.
that would be great. It's nice to meet you, Caitlin.
All right. Do we have any other questions or comments that for yes, she's excited to hear that. Yes.
Yes, yes.
Do we have any other questions for Dr. Brown Shirley today? And again, it's great to be able to have partners in the community, especially with the AIH AHEC, and knowing these practitioners like yourself and the research that you're doing, and being able to share this with audiences and participants that might not have been able to hear about this before. So we really appreciate
and if there's anyone else who's like wanting lunch and learns, if they want me or my team to go out and talk about concussion to your facility, to your program, let us know. This is what we do. We are all about community serving, or serving the community. So please just let us know how we can help.
Great. Thank you very much for that. And be sure to check our website for upcoming webinars. I know that Ernestine is working on our next presenter with our group. We're getting that put together. We have other webinars on our website. And again, this is recorded. So if you missed it or you want to share it with your colleagues, let them know. I will send out that link in my thank you email to everybody that connected. Looks like we have another comment here.
Yeah, she was just asking about the concussion laws in New Mexico. And I'm trying to, I personally, because I don't treat anyone from New Mexico, so I don't know the concussion laws, but you can very much just Google the concussion laws for New Mexico and see how they're different. Like I was just practicing in California, and athletic trainers are not allowed to clear for return to play in California. Yeah, so there's some differences between states for sure. But sorry.
So that's
Sorry,
a state regulation then. That's a state that's
it's a state law.
preparing
Yep.
those regulations. Okay, great. That's
Yep.
good to know.
Yep. That's unique to each state. But we all have concussion laws and regulations.
But they're just a little bit different. Okay, great.
Yes.
All right, we got another comment.
Oh, good. Monica says, I am really happy things have developed and trained. Developed in training on concussions. I had 2 athletes affected by concussion. They were back to baseline, fantastic, but it was tough at first to watch them heal through unbalancing movement and migraines. Yes, it can be very debilitating to experience concussions. It can change the person's life just like that. But the goal is that they're slowly going back to normal. A lot of people they get frustrated. They're impatient. They want to get back right away. But I have to tell them, oh, hold on, we might not get there. So people are surprised that it takes 2 to 4 weeks to get to the full recovery state when I mentioned that.
But it's that recovery piece that's the important part, to be able to get back to baseline.
Completely. And like recovery within a typical period is critical. Yeah.
That makes a lot of sense. All right. Do we have any other questions or any other comments for Dr. Brown Shirley today? Please go ahead and put them in the chat. And again, I'll be sending out a thank you email to everybody. It'll have the link for the evaluation. If you don't already see it behind the window, the Zoom window right now, please go ahead and fill that out in the next couple of days and for those certificates. And if you would like a certificate that's a non-CME one, you can respond to my email as well that I send out to you. I know we have quite a few healthcare professionals that aren't necessarily physicians, but we can get you a certificate for participating as well. Yes, the slides will be available on the website with the recording. And again, that link will be in my email to you. You'll be able to access that and any of our other past webinars that are recorded. You'll be able to see that. This one, of course, will be on the top of the list because it's the latest one. And we do have other ones that you can do a search. Absolutely. All right. And doesn't look like we've got any more coming in. So again, please, thank you for joining us. We greatly appreciate it. And Dr. Brown Shirley, again, thank you for joining us and sharing your expertise and your experiences with this. This is a vital piece of information, especially with school starting up again. I'm sure there's some of those high school students that are already practicing, getting ready for their school year. So
yeah, we're about to start on our busy season. So fall sports. I'm super excited. Spring is when we lull out, but now back, football starting, NFL preseason, it's right there, right around the corner. It's exciting.
Excellent. Great. All right. Ernestine, did you have any closing comments? Put you on the spot.
Yeah, no, Just thank you so much, Dr. Brown Shirley. You've collaborated with us on, a few events with the American Indian Health AHEC, and we really appreciate you, taking it one step further and presenting on today's webinar. We will, we're going to have additional webinars in the hopefully next month or so. We are working on additional webinars, and we'll announce those soon. And thank you, Arizona Telemedicine Program. We'll be seeing you guys in Sholo.
Yeah, so the Southwest Telehealth Resource Center and the Arizona Telemedicine Program, we're actually working with Summit Healthcare up in Sholo, and we'll be up there in August for a in-person event. You could check that information out on our website if you're interested. All right, without any further ado, then I'm going to go ahead and give everybody 5 minutes back to their day. Please go ahead and do those evaluations. Your input is valuable to us, and it helps us give us other ideas for webinars to bring you more educational content. Again, have a great day, everybody, and we'll see you next time. Thank you.